Hello and namaste everyone. I am Dr. Anjana Adhikari, MD Obstetrics and Gynecology, your faculty for Recall CEE 2077 session. So here we are solving the questions of Recall CEE 2077. Let's start. Question number 1 is treatment of stage 2B cervical carcinoma is. Options are here are trachelectomy, simple hysterectomy, radical hysterectomy with pelvic lymphadenectomy and chemoradiation. If you have gone through the staging and management of cervical carcinoma, the question is quite straightforward because anything beyond stage 2B cervical carcinoma is chemoradiation. So now let's simplify it and know further about staging of CS cervix. The slides look very cumbersome, so I'll try to make it easy and split it into different slides. Normally, any CS carcinoma is defined whether it is confined to cervix or it is extended beyond the other organs and mets. So stage 1 is always confined to the concerned organ. So here stage 1 is confined to cervix and stage 4 is metastasis. This is almost common for all of the cervical cancers or any other cancers. Now stage 2 is beyond cervix but pelvic wall is not involved, and stage 3 is lower 1/3 of vagina, pelvic wall involvement and lymph node involvement. Let's simplify it more further. So I also found this mnemonic in when I went through some videos. So mnemonic is mics are used by prime minister and very important persons or leaders to broadcast their broad messages. So let's see here what mic is for stage 1, prime minister is for stage 2, very important persons and leaders for stage 3, and to broadcast their broad messages for stage 4. So stage 1 is MI for microinvasive and B for visible lesion in cervix. So stage 1 is done here. Now for stage 2 is we have memorized it as prime minister, which means parametrial involvement. If there is no parametrial involvement, it should be stage 2A, and if there is parametrial involvement, it is stage 2B. Now VIP is for stage 3, VIP and L. If lower 1/3 of vagina is involved, then it is stage 3A. And if lymph nodes are involved, it is stage 3B. And stage 4 is bladder and bowel involvement or distant metastasis. B for bladder and bowel involvement and M for distant metastasis. So now defining into different treatment options. Ideally, before choosing any option, we have to go through the questions thoroughly, whether the question states the woman is young or if she is desirous of fertility or not. So we have options in stage 1A, either cervical conization or simple hysterectomy. Cervical conization is fertility preserving surgery, and hysterectomy is, of course, if the woman doesn't desire to save her uterus or she doesn't require any fertility in future. And stage 2 is also same, whether it should be modified radical hysterectomy when fertility is not desirable, and radical trachelectomy if she wants to preserve her uterus and fertility might be desired in future. And stage 1B2, with it is radical trachelectomy with pelvic lymphadenectomy, or it should be hysterectomy with pelvic and para-aortic lymphadenectomy. But from stage B onwards, stage 2B onwards, fertility preservation is not possible. So there should be either chemoradiation or surgery. And for stage 1B to 2A, chemoradiation and surgery have equal outcome. So while choosing options, we should choose if the woman is young and if she is, I should say, if she is young and we might think that she has a long life and she might require management options for CS cervix in future. So initially we should choose for surgery because she is young, surgically fit, and more healthier than older women. So either surgery or chemoradiation, both are equally effective. Now, as I already mentioned, from stage 2B onwards, it is always chemoradiation. And stage 4, where there already distant metastasis, either chemotherapy and plus palliative care, whatever is more effective and more good to the patient. Now, so we already explained for stage-wise management of CA cervix. Now, question number 2. This 58-year female presented on OB/GYN department with a history of postmenopausal bleeding. On screening with pap smear, 3 tests are found to be negative. Now, what will be the next test to perform in such a case? So, while reading questions, you also have to be careful that you are not misled by the misleading informations. Here, 3 pap tests are found to be negative, might be not so important to solve the answers. So, whenever solving questions, you take the disease such as postmenopausal bleeding and remember the causes. What should be the causes of postmenopausal bleeding? Most common cause is atrophy, whether it be endometrial or vaginal atrophy, and the second is carcinoma. So if there is atrophy, how will you find out? You can see it by ultrasound. So transvaginal ultrasound sonography would be our answer, which is more effective than transabdominal ultrasound. And if on transvaginal ultrasound, if our endometrial thickness is more than 4 mm, then you can go for endometrial biopsy. So here the straightforward answer should be transvaginal sonography. Now question number 3. Which method of labor induction should not be done in a patient with previous lower segment cesarean section? So what is the most important thing here is previous lower segment cesarean section, and what we want to avoid is uterine rupture. Uterine rupture which can be occurred due to excessive stimulation. So the options here are stripping of membrane, oxytocin, misoprostol and Foley's catheter. The stripping of membrane and Foley's catheter are mechanical method of inductions, whereby we try to release endogenous oxytocin and stimulate labor. But these methods are more effective when they are combined with medical methods. So let's remove these 2 options from our mind. Now the 2 remaining options, medical inductions, are oxytocin and misoprostol. Oxytocin is the most commonly used method for induction or augmentation, and which is relatively safe because oxytocin has a short half-life which is 3 to 4 minutes, and its action could be controlled. If we stop oxytocin for a while or reduce drop, then our rate of contraction might be controlled. But with misoprostol, we cannot do that as it has long half-life. So here probable answer is misoprostol. Now question number 4. Lady with 12 weeks of amenorrhea presented with abdominal pain. Internal examination reveals dilated internal os, but she denies passage of any mass per vagina. What is the most likely cause in this case? And the options are threatened abortion, inevitable abortion, complete abortion and missed abortion. So here the key information is abdominal pain, dilated internal os, but no passage of any mass per vagina. So whenever the case of abortion is there, you should look for 3 things: complaints, PV examination findings and ultrasonography information if there are any given. So in complaint it can be pain, bleeding, brownish discharge, and the pain and bleeding may be severe or just spotting or mild only. And on PV examination, you should always look for the finding of os, whether it is closed or open, and uterine size, whether it corresponds with period of gestation or not, and any information regarding ultrasound if given. So here in picture number 1, you can see the fetus is here, bleeding is present, but os is closed. So this is the case of threatened abortion. And in picture number 2, so the product of conception has started separating from its attachment. It has come down, but it is still inside the uterus. Bleeding is present, membranes are bulging. So from here, we cannot stop the process of abortion. So this is inevitable abortion. And in picture number 3, here you cannot see any product of conception, but some bleedings are present, os is open, and bleeding is still present. So it could be incomplete abortion since os is open. If the os has been closed and there are only minimal bleeding and no product of conception, it could have been a complete abortion. And in picture number 4, there we have product of conception, os is closed, not much bleeding, and uterine size is also a bit small. So this is a case of missed abortion. And last picture, picture number 5, there are no POC, os is also closed, no bleeding, active bleeding at present, so it could be a normal or case of complete abortion. So let's go back to the question. So here she has pain, dilated os, but no any passage of mass per vagina. So this could be process has already started and now we cannot stop it. So this could be a case of inevitable abortion. Question number 5. Which of the following antihypertensive medication is contraindicated in pregnancy? Now here we should all know that the drug of choices in pregnancy are labetalol. First, second is nifedipine, and third is methyl dopa. So first line is labetalol, second line is nifedipine, third is methyl dopa. In options we don't have nifedipine, and labetalol and methyl dopa are there. So these are the drug of choices. Now about hydralazine. Hydralazine is a drug of choice for hypertensive crisis along with labetalol. So all three drugs are used in antihypertensive medication in pregnancy, and enalapril only the one drug left, which is ACE inhibitor, and it is contraindicated in pregnancy because its side effect is fetal renal dysplasia, which might lead to renal failure and pulmonary hypoplasia of the fetus. So here the answer is enalapril. Enalapril is contraindicated in pregnancy. Question number 6. RBC count decreases in which of the following physiological conditions? So the options given are newborn, pregnancy, diabetes, and high altitude. So let's think about pregnancy first. Pregnancy is the case of physiological hemodilution, and so there is physiological anemia because plasma volume increases by 40 to 50% and RBC mass or volume increases only by 20 to 30%. So there is disproportionate increase which leads to physiological anemia and RBC count is decreased. So this is our probable answer. And in newborn, their blood volume is also high proportionate to their body mass. So this is not the options. And in diabetes and high altitude, these are the stressful conditions. And there is induced hypoxia. So hypoxia stimulates erythropoiesis by releasing erythropoietin and thus increase RBC count. So the clear answer should be pregnancy. Question number 7. Fetus is lying on the uterine cavity in breech presentation with thighs are flexed at hips and legs are flexed at knees. Which type of breech is this? So let's see the figure first. See here in frank breech, thighs are flexed but knees are extended. So this is the case of frank breech. In complete breech, thighs are flexed, knees are also flexed. So the presenting part may be buttocks and sometimes you might feel the fingers of the fetus toe. And in footling breech, as name suggests, foot comes first. So here the answer is thighs are flexed at hips and legs are flexed at knees. So this is the case of complete breech. Question number 8. Most common cause of maternal mortality in Nepal is. So this is the question which we have to mug up the answers, and according to annual health report, the direct answer is postpartum hemorrhage, and maternal mortality rate of Nepal as per 2077 is 186 per 1 lakh women, And our target is to decrease this maternal mortality by 70 in the year 2030. So let's see where we can reach in 2030. Now the next question is, pregnant women on antenatal screening performed a triple test. Her maternal serum alpha fetoprotein and estriol are low. So we have low AFP and low estriol. And her beta HCG level is high. What is the most likely diagnosis? So before coming to answer, let's see this picture first. I have simplified it. So these are the triple and quadruple markers. PAP-A is decreased in all the three conditions. So we don't have to remember it. Even if it's given in question, it should be decreased in everywhere. So let's see in the Down syndrome first. Beta HCG is increased and inhibin A is increased. Here I remember it as 2 and 1. 2 corresponds to letter B and 1 corresponds to letter A. So B and A, beta HCG and inhibin A, both are increased in Down syndrome. And in Edwards syndrome, almost everything is decreased, and in Patau syndrome, almost everything is normal except PAP-A. So here our answer should be, because alpha fetoprotein and estriol are low and beta HCG is increased. This is the case of Down syndrome. Now question number 10. Which immunoglobulin is maximally secreted in colostrum? And the options are IgA, IgG, IgM and IgD. I think all of you must be confused in between IgA and IgG, because IgG is the only immunoglobulin which crosses placenta, and you can remember it as G greets the fetus. And IgA is maximally found in secretions like saliva, milk, breast milk, etc. And IgG is most abundant in serum. So the answer here is, which immunoglobulin is maximally secreted in colostrum means IgA. Now question number 11. Most common type of carcinoma lung in female is. This is also the mug-up type questions. Lung carcinoma is divided into small cell carcinoma and non-small cell lung carcinoma. Non-small cell lung carcinoma comprises of 85% of carcinoma, and small cell carcinoma comprises of the remaining. And in non-small cell there is adenocarcinoma and squamous cell carcinoma. Adenocarcinoma is most common in females. It is around 44% and it is most common normally in non-smoker female, and squamous cell carcinoma accounts for the remaining, that is around 35%, and it is more common in smoker males. So here the answer should be adenocarcinoma. Now the last question. A young woman with history of 20 weeks of amenorrhea presented to the clinic with grape-like vesicles passing from the vagina. And ultrasonography findings show snowstorm appearance. How would you manage such case? So here the two hints are already in the questions regarding the diagnosis of the case. Grape-like vesicles and snowstorm appearance leads to hydatidiform mole. Hydatidiform mole. And if not followed up in time, or it might progress into gestational trophoblastic neoplasia or GTDs. So and see, the age of the lady is 20 years, so we don't want to remove the uterus in 20-year-old lady. So hysterectomy is ruled out. Methotrexate is usually used in GTDs which does not respond to dilatation and curettage, not exactly, which does not respond to suction and evacuation, and whether the beta HCG plateaus even after evacuation. So methotrexate is also not the answer. Usually we all confuse between dilatation and curettage and suction and evacuation because both sound same and similar. But dilatation and curettage is relatively dangerous because the uterus is very friable at this stage. So we usually don't do dilatation and curettage, and the most sensible answer only left is suction and evacuation, which is safe with using suction cannula. And by this we come to the end of our Recall CE OB-GYN solving question solving, and I hope you all do well in exam and you have enjoyed the video. Thank you and all the best.